Okay, thanks for sticking with me. So hopefully we'll cover some topics that will be helpful. So what I'd like to do is focus a little bit on bipolar disorder and specifically talk about the atypical antipsychotics in a little bit more depth because there's been some new information that has come out quite recently. We'll talk about anxiety and some specific focus on PTSD and also treatment of ADHD during pregnancy, which I think is often a topic that doesn't get discussed, but often comes up in questions. So I think people are more and more needing to know how to deal with it during pregnancy. And again, just to put in perspective, when we're talking about disorders that have a serious impact on health, and also potential medication risks, we want to keep in mind that the risk of congenital malformations is about 3% in this country. So really important, I think, that we communicate that with patients. And we know pretty much across the board that psychiatric disorders are associated with increased complications around pregnancy. So specifically, what we tend to see across untreated psychiatric disorders are prematurity, babies being small for gestational age or low birth weight. And so we want to take that into account as well, that women who are not well during pregnancy, it's not it's a very complicated milieu in terms of pregnancy, untreated conditions. And we also do worry a lot about the impact for the postpartum. A lot of patients, when they're not well, are going to abuse substances more, and also we want to make sure that when someone is going through pregnancy that they're really able to shore all their supports, that they're strengthening their relationships. And if a lot of women, when they're unwell, are really not able to do that, not able to really prepare themselves and their lives in order to bring a new baby into the world. So just a little quiz or matter of opinion. So just a case. What do you think? Ms. A is acutely manic. She's pregnant. She's not taking any medications when she presents. What is the most reasonable anti-manic agent to start? So the choices are lithium, valproate, topiramate, lamotrigine, and aripiprazole. Okay, so there wasn't just one right answer, and the most popular answers, I think, are the most reasonable. So, lithium gets tricky around the first trimester because of the known increased risk of Ebstein's anomaly, but it's a relatively small risk. So for women who are manic, it is probably the best characterized anti-manic agent. And depending on the clinical situation, may be very acceptable to use lithium during the first trimester. And aripiprazole, we'll talk about, has very little information. We'll look at the atypical data overall, but it is anti-manic, and atypicals are being used more and more in pregnancy. So valproate would actually be not a good choice, and that's because it is the medication that we use that's most associated with birth defects. Topiramate really doesn't have anti-manic properties, and also looks the small amount of data we have for topiramate does look a little worrisome in the first trimester. And lamotrigine is really, its claim to fame is really bipolar depression and prophylaxis of bipolar depressive episodes rather than acute treatment of mania. Okay, so in order to talk about atypicals, I just want to put that a little bit into context. So we know that that tapering and discontinuing, or even not tapering, but discontinuing a mood stabilizer in pregnancy or in anticipation of pregnancy is associated with very high rates of relapse. So about 70-80% risk of relapse for women who have bipolar disorder. And we also know specifically that the rates of postpartum episodes without medication prophylaxis are very high in women who have bipolar disorder. Now, the risks of untreated bipolar disorder, well, we would think they would be at least as bad as untreated depression during pregnancy because, mania, hypomania may lend itself to very poor self-care. But this is a study looking at outcomes in bipolar disorder. Women with the disorder had increased rates of C-section, babies being small for gestational age and prematurity. Malformations look similar with and without bipolar disorder, so women who have the disorder versus controls, although there is an increased risk of congenital malformations with mood stabilizer treatment. And that makes sense because we know that valproate, carbamazepine, lithium all have a known association with congenital malformations. Okay, and so in terms of lithium, what it really comes down to is relative risk. So we know that lithium increases the risk of Ebstein's anomaly, but the bottom line is that Ebstein's anomaly is a relatively rare condition. So even with the increased risk, it's still overall a small risk. So if a woman is a lithium responder and she's pregnant and she has a very severe course of illness when she's not on medication, then in most cases with that kind of scenario, it may make sense to continue the lithium throughout. Now, some women will try and discontinue for the first trimester. Some can be successful at that, some not. You know, it really depends on the individual. And you know, when there's so much unknown in any situation, the decisions have to be really highly collaborative. So some women will say, okay, I'm going to try coming off, you know, no matter what. And some women are so afraid of becoming ill that they'll stay on medication. And certainly there are cases where women will stop medication, become very ill, and often end up on more medication than they started with during a pregnancy, which is a really unfortunate situation. So the other thing too is, you know, it can be a little deceptive sometimes if someone's done really well for a long time and then they're approaching pregnancy and they've been on medication, because we don't know how much is perhaps course of illness being relatively good, and we don't know how much is that the medication's working. So I think, you know, most perinatal psychiatrists have had the experience where you think someone's done well for 8 years, they've been very stable on, for example, lithium, and then they come off and get really sick. You know, it's often the case that even small changes in dose result in someone getting very ill. So, you know, I would have to say that, you know, psychiatry is a very humbling disorder, and I think bipolar disorder is one of those disorders where when you treat it a lot, you have a lot of cases where even small changes really can make someone quite ill. In terms of lithium later in pregnancy, it is cleared more rapidly in late pregnancy. And so someone may have declining levels. So we can watch for that therapeutically or clinically and increase if indicated. And typically in our program, we follow blood levels about once a trimester, and then postpartum. I would follow thyroid and renal labs as well throughout. And then, you know, really the anticonvulsants are a tough class. So valproate, the risks sometimes are even reported as higher as 5% of neural tube defects. And as I said earlier, the more we learn about valproic acid in pregnancy, the worse it really looks, because it's been associated with longer-term neurodevelopmental problems. So, you know, kids scoring more poorly on neurocognitive tests. And so following kids up at 3 years and also at 5 to 6 years of age, we're finding that out, whereas we talked about that in contrast to lamotrigine, where kids seem to do about the same as the general population in terms of how they're doing in terms of neurocognitive outcomes. So lamotrigine's category D is due to the fact that there have been some registries that show a small risk of oral clefting, and some do not show that, but some do. So that's where that comes from. However, we do have a lot of data regarding lamotrigine in pregnancy. It's extremely well characterized. So, you know, that's in contrast with some of the other medications we use in bipolar disorder. So in my opinion, based on the evidence, I really think that lamotrigine is really a first-line option for bipolar depression. Of course, it doesn't work acutely because you have to start at a really small dose and titrate up. It can take months to get the patient stable using lamotrigine. So if someone does present on lamotrigine, it really is the last thing I want to think about discontinuing, and think about that really carefully. So antipsychotics are being used more and more in pregnancy, you know, mostly related to the growing use of atypicals across different disorders. And so already a bit out of date, so 2007, almost 1% of pregnancies in this country, women were using atypical antipsychotic medications, and so that's a really growing percentage of pregnancies. And during the course of time during the study, there was a pretty dramatic increase in prescription rates as well. And probably in parallel with use of atypicals in general, the reason women are getting atypicals, treatment-resistant depression, bipolar disorder, and schizophrenia. So in terms of first generation or typical antipsychotics, they've been around a very long time. There isn't as much data with them as we tend to see with, for example, lithium. But we do have information that's showing that the higher potency typicals do look reasonable, do not seem to be associated with any pattern of any kind of birth defect. So I would say in general, when individuals are selecting typicals, that I've seen more haloperidol used than other typicals during pregnancy. So it's not considered a teratogen. There have been, and this is a small study, a small prospective study that didn't show any increased rate of malformations above the rate in the general population. And also a very, kind of in this prospective study, a difficult thing to attribute to any one thing such as medication. Higher rate of elective termination, preterm birth, lower birth weight, all of which could be due to underlying disorders. So are atypicals associated with any major malformations? So the first study that came out on this topic was done by the Mother Risk Group in Canada. And it's a few years old already, so 2005, which is before many of the ones that we use often were even available. So they grouped together atypicals, and they compared them with women, healthy women, no medication. That's the control group typically in teratology center studies. And they found that despite a higher increase in risk factors, like not using prenatal vitamins, being older, being smokers, there was not an increased risk of malformations among the atypical users compared to controls, and generally low rates of malformations. But again, it's a small study. The other thing you can see is for some of these medications how really small the numbers are too. A German study that recently came out was much larger and complicated, and really it was a very complicated paper if you take a look at the original source. They looked at women exposed to atypicals, those exposed to typicals, and then a control group, so no medication, no disorder. And they found that there was not a difference in major malformations between the typicals and the atypicals. So there wasn't a significant difference between those. But there was a significant difference between those taking medication versus the healthy controls not taking medication. Okay, and then another study that recently came out, again from the Mother Risk program in Canada, looked again at women taking atypicals in a prospective study. This group, compared to the first study that came out from that program, had a greater number of women who were taking quetiapine because its use had increased over the years between the studies. And they found, again, no difference in malformations between the group taking medication versus healthy controls not taking medication. Okay. And in terms of schizophrenia, in terms of looking at risk specifically for women who have schizophrenia, this is a study from Taiwan. They looked at rates of those women who had schizophrenia taking medication versus not taking medication. They didn't find a difference in terms of low birth weight, which is the LBW here, preterm births, a length of gestation, LGA, and small for gestational age, SGA, compared to moms who were on atypicals versus those who were not on medication. And then moms who were on typical antipsychotics during pregnancy did have a higher risk of preterm birth. So, it's one of the things also about comparing the different groups of medication, so it's not clear what would warrant a woman getting a medication from one class versus another class. Would there be a difference in severity or presentation? So that's something that we just don't know. Now, one of the issues that's come up around antipsychotics in general has been case reports about neonatal symptoms that have come out. So very similar to antidepressants, problems being described. So it's been described that babies can have restlessness, tremors, and feeding difficulties, Parkinsonism, so different differences. like with antidepressant exposure, tend to be short-lived, and we really don't have long-term behavioral outcomes on these medications at all at this point. So in February 2011, though, the FDA did issue a warning about this, about neonatal effects after antipsychotic exposure. And this is really like kind of a mess. I'm not saying that it's not possible, but I'm saying that this warning is kind of a mess. And that's for several reasons. First of all, this post-marketing surveillance system doesn't take into account a denominator. So if you have a certain number of people call and report cases, you don't know how many people were out there using the medication and had no problems, or you don't know how many people out there had babies with symptoms but didn't report. So it doesn't really give us a good sense of what the risk is. It doesn't really give us much data at all about rates of occurrence. And then the other thing is that we know from almost every study that's been done looking at outcomes with atypicals, and in this case, that women are typically not just on monotherapy with an atypical. So it's very common that women are on antidepressants plus atypicals. So the neonatal effects that we may see with atypicals could actually be related to antidepressant exposure rather than atypical. So we just don't know that as well. We also don't know what contribution the underlying disorder may have as well. So this is a study actually that looked at a very important question because it's been raised. It would make sense to wonder whether or not exposure to atypicals in pregnancy would increase the rate of gestational diabetes, which is something that hasn't been well studied. And so this is a study looking at maternal metabolic effects of being on medication during pregnancy. So in this study, they looked at different groups. So group 1 was olanzapine and clozapine. Group 2 was other antipsychotics. Group 3, no antipsychotics, so healthy controls. And they found that the antipsychotic users, like in the other study, had more risk factors. They were older, they were more likely to smoke, they were more likely to already have high BMI, often single mothers. And they did find an increased risk for gestational diabetes and babies being small for gestational age in both groups 1 and 2. Okay. So another question has been posed, like, are there developmental outcomes that we should be concerned about? And I have to say the bottom line is that this is an area where we don't know very much at all. This is a study that looked at infant development, looking at a battery called the Infant Neurological International Battery. And they looked at habituation, so repeated exposure to a stimulus and what the baby's response was, and did it diminish with repeated stimulus. And they looked at an antipsychotic group, antidepressant group, and they looked at a non-medication healthy control group. And I just want to show you, this is why I'm kind of saying that we don't have much to work on, is because this is, I think, very typical of some of these small studies, is that you can see that we're grouping together atypicals and also haloperidol, which are generally represented by very small numbers. So it's certainly possible that one medication may carry different risks than the others, but we're kind of lumping them all together in really tiny numbers. And then the other thing that's really important, I think, to look at that adds to the confusion is that if you look at the antipsychotic group of 22 patients, so small already, the majority of them were also on an antidepressant, which makes it kind of hard, I think, to attribute any factors that one may see to any particular cause. And so what they found was that the scores did seem to be related to maternal psychopathology. So the moms not being well did contribute to worsening scores on the developmental tests. And they did control for some covariates, and they did not find any effect of the medications on habituation. But they did also find that infants in the antipsychotic group had lower scores than the other two groups. So, it's not clear. Those patients were generally on more than one medication. It's not clear if it was contribution of antipsychotic. It's not clear if it was simply severity of disorder. It's really unknown. But what the authors concluded, which I think makes a lot of sense, is that there certainly could be an additive component of medication exposure, perhaps polypharmacy, and then also severity of illness. So I'm going to make a really shameless plug for our antipsychotic registry that's housed at Mass General. We're enrolling patients. There's about 400 patients in it right now, and it's really carefully prospectively done. So if you have any patients that are pregnant, non and atypical, it's all by phone, 2 phone calls in pregnancy, 1 phone call postpartum. So there's about 400 patients enrolled right now. The first outcome data were presented at a teratology meeting in June, and the findings were not unblinded in terms of what medications were associated with what outcomes or what control, who was on controls, but rates of malformations in this study are quite low. They're generally at or below the rates in the general population. So what that tells us is what Lee Cohen, who's the PI of the study, would say is that we don't have thalidomide here. Like, we don't really have 400 patients is too small to have any definitive results. And what we have so far otherwise is too small to have definitive results. But the bottom line is that if it were truly like Depakote or of medication with high teratology potential, we would see a signal in this study, at least if it were one of the medications that was most highly prescribed during this time period. So obviously, some of the newer ones, we have extremely low numbers. But please, please, please do keep it in mind for patients that you see who are pregnant. The other thing is every pregnant patient you have would be eligible because she could serve as a control if she's not on medication. Okay. Now, another issue that comes up is what we do to prevent postpartum severe illness. So in cases with postpartum psychosis, which is definitely an emergency, a very, very serious condition, most of those cases turn out to be bipolar disorder. But we do have situations where women will only have psychotic episodes or manic psychotic episodes in the postpartum. So we don't actually know if those are the same things. It's usually assumed that if someone has a postpartum psychotic episodes, that they have bipolar disorder. They're often treated with mood stabilizers for a length of time afterwards. But it's really unclear if that's the same psychopathology as someone who's had bipolar episodes both during the postpartum time and not circumscribed only to the postpartum time. So this is a study that came out in 2012 that I think is probably the best at potentially giving us a handle on that situation. And that's that if a woman has no psychiatric history whatsoever, no mood episodes, and then has a postpartum psychotic episode that's treated, resolves, and then doesn't show itself again, and then she's approaching her next pregnancy. First of all, we know that postpartum psychosis is highly recurrent. It's reported to reoccur in about 80% of cases after a next pregnancy. And then, so those patients were compared to those who had diagnoses of bipolar disorder, recurrent bipolar disorder. So they looked at the difference between rates of relapse during pregnancy and postpartum with and without prophylaxis. And what they found for bipolar disorder was completely consistent with everything else that's been reported about bipolar disorder, that medication discontinuation is associated with high rates of relapse both during pregnancy and postpartum. And for the women who had these really isolated postpartum psychotic events, that they generally made it well through a subsequent pregnancy, and then had rates of relapse that were fairly high postpartum. And starting a mood stabilizer or antipsychotic, like in the immediate postpartum, like right after delivery, did decrease the response of a recurrent postpartum psychotic episode. So I just want to give an example of like how puzzling this can be, because I think at this time we don't really have a right answer about what to do if a woman has had postpartum psychosis, no other mood episodes, really how to treat that woman going forward. And so, for example, so I have a patient who, extremely high-functioning executive, came in after having had a postpartum manic psychotic episode. That was the only episode she had ever had. She had been treated she was hospitalized postpartum with a psychotic episode, treated with 500 milligrams of quetiapine, stayed on the medication for 2 years, looking absolutely fantastic. No side effects. She wasn't even tired, unbelievably, and was planning another pregnancy and really wanted to stop the medication. And I was extremely worried about her stopping the medication. But over a course of something like 6 months, we really carefully tapered the medication. She did like everything according to her own schedule. She actually became pregnant really soon after she started trying. We checked in regularly during pregnancy. She was rock solid stable. And then we talked about in the 3rd trimester restarting quetiapine to prevent a postpartum psychotic episode. And she did restart quetiapine in the 3rd trimester, because often starting postpartum may be too late because women can get really sick really fast. So she went back on the medication, even increased the dose postpartum, and then I got a very unfortunate call from the husband in the postpartum saying that she was starting to act crazy, thought she was like one with the neighbors, and really not acting like herself, really having bizarre beliefs. She went to the hospital. She actually started quetiapine, and within a few days was completely back to her normal self. She admitted that she had started to have what must have been some delusions and had stopped her medication, though. So we don't know, how breakthrough the psychotic episode was, versus what was not taking the medication at that time. But she was clearly vulnerable to a psychotic episode in the postpartum, but not otherwise. And so there's a really interesting question now of what should be her long-term plan. So the truth is I have to say I don't know. And so one part of the plan is that she's not going to have more children. And that was actually a really difficult decision with she and her husband. They came in, they talked about it. He was part of the plan from the very first consultation. And then the other question is, should she be maintained on a mood stabilizer? So just an informal poll. How many of you would continue quetiapine now that she's completely well? Okay. And how many of you would discontinue it? Okay, so similar numbers. I think most people said they would continue. I think, sort of the standard response, I think, based on our association with postpartum psychosis and bipolar disorder is to continue, but I'm not 100% sure she needs to be on it. So at this point, she's actually kind of made peace with the fact that she has a bipolar diagnosis, and she's staying on it for now. We've lowered the dose somewhat, so she's on a lower dose than she had originally come in on and responded to postpartum. But these are the kind of things that we honestly just don't know. What I think is so important, though, when regard to postpartum psychosis, I think the key is really family education. Because the people closest to the patient are going to be the ones that see her becoming sick, see those really subtle signs that may all of a sudden it may kind of blossom into a florid psychosis. And so I think that's really the key in terms of the mom's safety and safety of the children. I've just been amazed with postpartum psychosis and seeing women come back planning future pregnancies, just how crazy, how much craziness families will tolerate before seeking mental health care sometimes. And, I've mentioned it before in different years of this conference, but in a short period of time, I saw 2 women whose families went along with exorcisms before seeking mental health care. So, it's just kind of amazing, sometimes. First of all, the woman has terrible insight, but, families really don't know what's going on. And oftentimes, this is my own personal hypothesis. This has not been studied, but I think oftentimes because delusions can be religious in nature, I think sometimes individuals will present to clergy before they'll present to mental health care providers. Okay, so switching gears to talk a little bit about PTSD and pregnancy. So the rate among women is actually higher than that around men. So about 10% of women will have 10% of women during their lifetimes will have PTSD. And it's thought that part of the nature of trauma may explain at least some of the gender difference. So because women may experience sexual trauma at higher rates than men, and sexual trauma appears to be kind of an exquisite vulnerability to PTSD, that itself may increase the risk. Now, among veterans, women do experience military sexual trauma at higher rates than men, although it is strongly suspected that men underreport more than women probably underreport. And then in terms of war zone exposure, the actual combat exposure seems very similar. So more than half of women in the U.S. are exposed to at least one traumatic event, and actually more men are exposed to at least one traumatic event. And then I won't repeat myself. And in terms of the aftermath, these are, I apologize, I already said that. In terms of risk factors, so severity of trauma matters, type of trauma matters. Women do appear to have higher rates of PTSD even after similar trauma than men do. And of course, childhood abuse plays in greatly. Okay, so in terms of the military, this is becoming a hotter and hotter clinical issue as well as political issue, but almost a great majority of women in the military do experience sexual harassment, and a pretty high percent experience rape as well, about 6%. Okay. So looking at rates within recent conflicts, about very high rate, 21% of women screen positive for PTSD, compared to 33% of men, so higher in men, but men are generally the ones who are experiencing more of the combat trauma. And in terms of treatment, I'm just borrowing this from the Veterans Guidelines. In terms of first-line treatment, cognitive behavioral type psychotherapy is our first-line treatment, which would make a lot of sense for women who are pregnant, so no medication exposure. And then just another quiz question, what is the most evidence-based monotherapy for PTSD in terms of medication? So 1, antidepressants, 2, benzodiazepines, 3, atypical antipsychotics, or 4, anticonvulsants. Okay, right. So absolutely, the majority of you picked antidepressants, which is correct. So when we look at medication, the serotonergic antidepressants, the SSRIs and SNRIs are really the best studied, most evidence-based monotherapy treatment. There's some evidence also that the atypicals may be helpful as add-on, but not as monotherapy. And with benzodiazepines, there's a question of whether they should really play a role at all. So a question of whether they may be more harmful than helpful, although they are very commonly part of the regimen. So women veterans with PTSD are more likely to be prescribed medication for PTSD. They're more likely to receive benzodiazepines, less likely to get antidepressants, and also less likely to receive prazosin. So there are different medicating guidelines right now. And in terms of pregnancy and PTSD, this is again from the VA system. Pregnant women in the VA system have more diagnosable psychiatric disorders than non-pregnant women in the VA system as a control group. So as you can see, they have higher rates of just about every disorder well represented among pregnant women. So, it's really a dilemma. So we have increasing numbers of women in the VA system in the military, and typically not a tradition, not a big tradition of specializing in women's mental health in the VA system, but they're really becoming, a major caregiver for women really across the reproductive lifespan. So the VA has had an increased interest in women's mental health. In fact, at Mass General, we're working with them on a steering committee to develop a curriculum for their providers to treat women around reproductive events, which I think is really, an amazing effort on their part, considering the women that they have, the growing numbers of women that they have now and that they will have. So in the community, it's also true that there are fairly high rates of PTSD. So it's estimated to affect about 8% of women during pregnancy, and is often, as you know, comorbid. So now we know in general from anxiety, not specifically from PTSD, but anxiety, that it is also considered an exposure for the fetus. And I think, in my mind, if you really think about a panic attack and the body's response to a panic attack, it would make sense that it's a physiological exposure for the baby. There's stress hormones and a lot of physical things that go on. And we do know that there's a long-term impact on central nervous system development, so not CVS. CNS. I was probably thinking about shopping at the time. So we do know that probably the most consistent finding, and there was just a study that I saw on PubMed actually yesterday and didn't have time to add, a new one, showing that one of the more consistent findings is that prenatal anxiety does seem to impact attentional problems in kids later on in development. Okay. So we also know that kids are at higher risk if their parents have PTSD, and the effect of pregnancy does seem to have a biological impact on development of stress response in babies. So this is a study from 9/11 in New York looking at women who had and did not have PTSD in development, and they found lower salivary cortisol levels in babies of moms who had PTSD, so a different biological stress response between babies whose moms had PTSD versus those who didn't. Okay, so in terms of risks and benefits of medication in pregnancy, it would really a lot of what we would say for depression really carries over for anxiety disorders as well, including PTSD. So what we know about the antidepressants again would have to be weighed on an individual basis for women who have PTSD, but there are other medications as well that are being commonly used for PTSD. So we talked about these already in general. One of the medications being used more and more is prazosin, which actually has no systematic data in pregnancy. And we also discussed atypicals as well. So prazosin, it's category C, but again, that's something that doesn't really inform us very well. So it's been used, if you look at written reports in the literature, it's been used for hypertension in pregnancy with a really kind of a small look at outcomes of babies, but hypertension in pregnancy carries its own risk, so it's really hard to sort out what would be hypertension versus what would be medication exposure. So we don't really know, I would say, anything systematic about prazosin in pregnancy. Also, some women will develop PTSD in relation to childbirth. So sometimes after a difficult childbirth, women will develop symptoms of PTSD and then experience symptoms during subsequent pregnancies as well. Now I'm going to switch gears again and talk about ADHD, which I think is a much more commonly experienced dilemma in terms of treatment as the years go on, and more women who have adult ADHD are recognized as having it. So ADHD is estimated to affect about 4% of adults, and does have a substantial burden of impairment associated with it. And there is a wide range of severity, so there's a lot of heterogeneity in terms of what untreated ADHD means to individuals. So there's a growing appreciation for girls that have ADHD that many of them will retain the disorder as they get older, and that a substantial minority of them will have significant disability from this. So no studies have really evaluated the course of ADHD across pregnancy, which potentially could be an extremely fascinating study. So many women complain that their memory is not as good during pregnancy, that there's like this pretty common myth that women have like pregnancy brain. There could be a hormonal impact on cognition. Another thing is women can be very distracted during pregnancy. This is just for the normal pregnancy experience. And then, of course, treatment decisions are impacted by pregnancy. So someone could be doing really well on treatment and then stop treatment for pregnancy, and then there could be implications of the severity of the disorder, particularly if pregnancy worsens it. So at this point, we don't really have a lot of evidence to know, what women would be at risk of worse functioning, except to really go by their experience pre-pregnancy. So it's actually debatable whether pregnancy worsens generally neurocognition in general. So not for women with ADHD, but just women in general. So there are some studies that specifically try and parcel out, like, are certain hormonal changes related with greater neurocognitive dysfunction or complaints. And basically there are inconsistent findings. So some studies show, in this trimester, this might have an impact. Some say postpartum, this might. So there are basically no consistent findings, which means that on an individual basis, some women may experience changes, but they're not universal, and they must be subtle enough that they don't really follow a specific pattern. But it is possible that women with pre-existing ADHD could represent a population that's especially vulnerable to hormonal changes. We just don't have any study to support that or refute that. So, and there are really variable risks of stopping pregnancy. So women often come in and they're on a stimulant and they want to know if they can continue or not. And so it's a tough question, because for some women, one of I think the key questions is how does the woman drive when she's not treated for her ADHD? That's a big question, because I've asked some women that, and some women will say, oh, I'm a terrible driver. I have car accidents all the time when I'm not taking my medication. That makes my work pretty easy. And then for other women, they don't have to drive, so they can use public transportation or make accommodations. But we definitely don't want to put anyone in an unsafe situation. There are also women that say that they cannot do their jobs if they're not treated. And a similar situation, I've had patients who use stimulants for narcolepsy and are in an unsafe situation as well if they're not on stimulants. So there are a small percentage of patients who come in where it really looks like they need to be on the medication. For the much greater percentage of patients who come in, it's a really gray question. Certainly there are a lot of women who can function good enough off their medication, and for the most part I think they should be absolutely supported to stop medication for pregnancy. Many of them can decrease their work or school load during a pregnancy. Their employers may be able to help out. And for many women, they really did very well in life. Some women who've had ADHD and have not been on the medication but were high achievers until they really got really far ahead in school and finally got diagnosed. Many of those women are used to coping with symptoms and for a period of time can come off medication without great harm. So another question, what risk is most associated with stimulant use in pregnancy? Number 1, neural tube defects. Number 2, cardiovascular malformations. 3, babies being small for gestational age. Or 4, excessive weight gain. Okay, so the most common reported outcome is babies being small for gestational age, which most of you guessed correctly. So now the tough thing is most of the information that we have on stimulants in pregnancy comes from substance abuse populations rather than women with ADHD. We have extremely limited evidence on women who are prescribed a stimulant for ADHD and take it as directed during pregnancy. There's a limited amount of that kind of information. But and of course we know that women who are abusing substances also have a lot of other exposures and lifestyle factors that may also contribute to complications in pregnancy or different pregnancy outcomes. So in general, there was a recent report specifically looking at outcomes in women with ADHD, and they looked at also women who were on other medications as well. The most frequent delivery complication was neonatal hypoxia, so it's hard to exactly know what that means. And the most frequent side effect was decreased maternal appetite, which would make sense. Babies do tend to be smaller if they're exposed to stimulants during pregnancy, and that's true both in animals and in human studies. And so far, it looks like stimulants do not increase the rate of malformations, so do not increase the rate of birth defects. So there's a study cited here looking at that, and in the Journal of Clinical Psychiatry, which came out after my slides were in, we had to be due in, also showed the same thing, that exposure to methylphenidate in first trimester of pregnancy does not appear to increase the risk of cardiovascular or any malformations, congenital malformations. So really the key is generally development, and timing of exposure may impact fetal growth, where later in pregnancy seems to have the biggest difference in terms of the baby's developmental curve, size-wise, compared to earlier in pregnancy. And that also overlaps with when babies are growing the most size-wise in terms of pregnancy. So it may be that there are more subtle effects early in pregnancy, but we don't really see them as well till later pregnancy, till babies are getting bigger anyways, and there's more of a difference that can be noted. So it appears really, especially the third trimester, looks most vulnerable for babies being small. Now, that said, in terms of this data looking relatively reassuring for congenital malformations, I would not at all use these medications lightly in pregnancy. I think there's a lot we don't know, including long-term effects. So in general, for most patients, I do have them stop stimulants during pregnancy. And I have to say that also in breastfeeding, it makes me nervous, even though there's likely a very small amount of exposure. The things that stimulants can have an effect on like appetite and sleep, I would worry a lot about in infants. So in general, if a woman can do without a stimulant during pregnancy and breastfeeding, I definitely think she should do so. I think there are rare cases where safety may be a factor. There may be like dire circumstances like financial, occupational functioning that may factor in. One of the things about stimulants, though, is that they don't have to be taken every day, like an antidepressant medication or a mood stabilizer. So if somebody absolutely needs one some of the time, they could actually take it some of the time to really limit use. So with behavioral teratogenicity, this is an area where we really have no information. The closest we really have is really, substance use population. So what are the long-term impacts of cocaine exposure? Well, it was thought a couple decades ago that there were really serious, terrible long-term implications, and we actually don't really know that to be the case today. So it's been reassessed that, don't quote me on this, but cocaine doesn't look as bad as it was once thought during pregnancy, not at all making a case for it. It doesn't appear to be as bad as was once thought. So, I really think that in terms of stimulants, in terms of antidepressants, really in terms of all classes of medication, what we really need to have are these pregnancy registries where kids can be followed up long term to know, because we just don't have a good answer for people right now. Okay, and in breastfeeding, there have been case reports of generally small amounts in breast milk, but with that said, I still err on the side of caution and advise women not to take stimulants while breastfeeding. And then with atomoxetine and guanfacine, we really don't have any systematic information about these in pregnancy. So if they can be avoided, if possible, we encourage women to stop them. Okay, and then psychotherapies. I think that there's varying amounts of access for psychotherapy specifically for ADHD, depending on where you are geographically. But if women can get cognitive behavioral therapy or executive functioning coaching, that can be an extremely helpful and important non-medication treatment.